All right. Welcome back, everyone. Thank you again for another night of training, attending another night of training. Really happy to see all of you here. And despite what the name might make you think, it's actually a very uplifting training that you're about to see, with lots of good information that might make you feel better about what you might be feeling a little anxious about when you're in your role at Tubman. So, encourage you to really just try to engage as you can in the large group discussion, whether it's on chat or piping up on the microphone. But as you all probably know by now, I am Katie Massey. I'm the Intern and Volunteer Services Coordinator. And with us tonight is Laura Colodoro, and she's going to be facilitating the training tonight. She is a therapist at Tubman, and so that's why we thought she would be well equipped to talk a little bit more about trauma, as well as the services within her department. So, Laura, would you like to kind of say maybe a little bit more about yourself before you start?
Yeah, thanks, Katie. Yes, hi everyone. I'm Laura. I use she, her pronouns. And yes, mental health therapist and clinical supervisor at Tubman. I've been at Tubman for about 9 years now, which sounds so long when I say it. I can't believe it. But really love it here, and have never wanted to leave. So here I am. Yes, tonight we're going to be talking about an overview of our clinical services, just so you all can get a little bit of an idea of the different things that we can do and ways that we can support clients in the clinic on the clinical team, and then some different skills, just like some different kind of basic soft skills for interacting with clients, regardless of what your role is. Even if you're not in a clinical role, these can all be useful, and will hopefully be helpful. So feel free to ask questions throughout if they pop up. Otherwise, we might have some time at the end. And yeah, we'll get going here. Okay. So I'm going to preface this by saying that all of the services that I'm going to talk about here, it's all in your program guides in even more detail than I will go over tonight. So don't feel like you have to remember all of these different services that I'm going to go over, but sometimes it's nice to hear a little bit about them anyway. Um, so we can work with clients in various different capacities. A big part of what we do is individual therapy. We have about 13 clinicians on the clinical team, who can work with clients doing individual therapy. That tends to be mostly adults, but we also get a handful of adolescents seeking therapy, and then every once in a while, a younger kiddo, somewhere between age like 5 and 10. We don't get quite as much of that. We don't have as many people on the team who work with kids, just because, again, we don't see as much of it. So a lot of adult individual clients for individual therapy, some adolescents, some couples here and there, will call in seeking services. Families, again, not quite as common, but every once in a while, or maybe like a family dyad, like a mother and an adult daughter or something like that. So sometimes we'll get variations of family therapy like that. And then we can also do mental health assessments. Sometimes people are just for themselves seeking a one time assessment. More often than not, these mental health assessments are clients who are calling in to get a mental health assessment because they're required to, like they have some kind of like court case or probation that is requiring them to get a mental health assessment. So they just need a one time mental health eval and diagnostic assessment write up. So that's something we can do. Again, we don't get a ton of those, but on a semi-regular basis, we get a few. And then chemical health assessments too. So we have two LADCs, licensed alcohol and drug counselors, on the clinical team, and they can do chemical health assessments with folks who are seeking treatment. Um, and they just do the assessment, and then they can make referrals and recommendations to treatment programs in the area. So those are some of the things that we can do, and those are all done right by a therapist on an individual level. And then we have groups. Most of our groups are co-facilitated by staff and clinical interns. And then the Relationship Violence Intervention Program and the DBT program I want to highlight those two specifically because for both of those, we have multiple different group options. So the client would only attend one group a week, but we have multiple options on different days or at different times just to give people a little bit of variety depending on what works for their schedule. The relationship violence intervention program is, again, another one that is often attended by people who are court mandated. They have been charged with something that is related to having engaged in abusive behavior. And so they now have a case or are on probation and they're required to do a group like this. So it's psychoeducation. It's focused on providing education about abuse and violence, as well as emotion regulation skills, communication skills, just ways for them to handle stressful interpersonal situations more effectively, and not engage in abusive behavior. So we have a few different groups, different days and times for that. And then dialectical behavior therapy, that is a program that almost everybody is self-referred to. It was originally created for folks with borderline personality disorder, but now it is attended by folks with a lot of different presenting concerns, depression, anxiety, trauma, and then, yes, sometimes still borderline personality disorder, bipolar disorders. Just it's really for anyone who's struggling with being able to manage and navigate their emotions in a healthy way and create and maintain healthy interpersonal stable relationships. That's a really long program. It's 13 months long, so it's over a year-long commitment. And clients attend the group every week and also an individual session with a DBT therapist. But it's really great. It's evidence-based. Clients tend to really like it. Yeah, really great resource there. Same thing, multiple groups, different days, different times. And one of them is a queer specific group. Queer specific DBT group. So those are those two programs. And then we have some standalone groups, the relapse prevention group for women identified clients who just want some extra support around their recovery. Really, that's the only requirement of that group. A relapse doesn't have to have occurred. It's just they want some additional support in their recovery. There's no commitment to how long they attend, though typically people do try to attend somewhat regularly, but it's fairly flexible. The trauma skills group, that's another really popular group. We've had it for many years. And it is for any client who is just struggling with ways that their past trauma is showing up in their life currently. So it's another one that is very heavy on psychoeducation, really helping to teach clients more about trauma, the different ways that trauma can manifest, why it manifests in that way, and then being able to get more aware of triggers, symptoms, and different skills and resources for how to manage those things. Just looking at the chat here as Outreach Advocate. Thank you. Good question. So double checking here. All of our groups are 18 plus. So we can serve adolescents on an individual level, but all of the groups are 18 plus. So I know sometimes youth is defined as up to age like 21 or 23. In that case, yes, definitely. But the groups are 18 and over. Yeah, great question. Okay. All right. And then we have the healthy relationships group. This is a group. I think it can get a little bit easily confused with the relationship violence intervention group because a lot of what is covered is similar. The difference is that the relationship violence intervention group is more structured. It has a set time. It's 21 weeks long. There's a much more strict attendance policy, especially with that being a court mandated group. Clients are required to meet a certain number of hours in order to essentially complete their case plan for probation. So that group is much more structured. Even the format of group is a little bit more structured, mindfulness, check-in, topic for the night, teaching. And the healthy relationships group is a little bit more open. Scheduling wise, it's more flexible. It's clients who are self-referred, so they, ideally come regularly. The hope is with all of these groups, people come somewhat regularly, with one exception that I will mention. But yeah, so the healthy relationships group, a client could come for a month, right? They could come and attend 4 sessions and have that be it. It has a much looser attendance policy, things like that. But it is focused on and it's also, rather than having kind of a set, this is our topic, this is what is being taught or discussed each night of group, it's a little bit more based around what are the clients bringing that day. So if all the clients show up and they check in and they share what's going on, and it's clear that multiple clients are struggling with boundaries or with, this particular aspect of parenting, then that's what they'll focus on for the rest of group, and just have it be a more flexible, supportive space. So that's that group. Expressions of Healing group is an art therapy group. So that group, again, all of these groups just meet once a week. In the Expressions of Healing group, they do mindfulness, they do art, they have a different prompt every week, and then they share and process specifically around the art that they created and the topic that they were focused on. So really cool group there. Clients really love it. We also have a chronic health conditions group. This is a newer group, but wow, it filled fast and it is staying full. I think that just shows there's such a need for it. So chronic health conditions group is, again, co-facilitated by 2 staff, and a little bit of a blend, kind of similar, like I've been talking about some of these other groups, a blend of the facilitators bringing content and bringing different like skills and things that can be helpful for managing health conditions, but also some openness for processing and sharing and whatever is coming up for clients that week or that day. So sort of a balance between skills and education and process, which, yeah, is kind of a theme with a lot of our groups. And then lastly, we have Melissa's Connections, and this is the one that I want to flag. This is sort of an exception. This is a free drop-in support group. So super low barrier to entry. Clients don't need to commit to any sort of time frame, amount of weeks that they're going to attend. It is, and if they don't have insurance, that's okay. All of our other groups, most of the time, clients go through insurance for those groups. Melissa's Connections, it's grant funded, so it's totally free. Clients don't have to do an intake in order to join and start this group. They can come one time if they want, or they can come every week. We have some clients who come to that group regularly. So really flexible, really low barrier to entry, free drop-in support group, Melissa's Connections. And sometimes it's facilitated by staff, sometimes it's facilitated by interns. Sometimes we'll have oftentimes two of our clinical interns will facilitate that group together. But yes, really great resource because it's so low barrier to entry. Okay. And again, all of that information and more is in your program guide. And the nice thing is, to get signed up for any of those services, clients can just call this one number. That's our intake number, our clinical intake team. They're wonderful. They're so helpful. And they are just a one-stop shop for being able to get registered for any clinical service. Any questions here? Okay. Sounds good. We'll keep moving. All right. So we're going to switch gears a little bit. We're going to start talking about some different terms, and then we'll go over some skills. So this is kind of a nice way for us to start. Let's just talk about a lot of the terms that I've already used and we're going to keep using tonight, and sort of as a group come up with a good working definition for some of these, because of course there are lots of different ways that we could define some of these terms. So what comes up for everybody? You can throw it in the chat, you can unmute and say it, but What comes up for you when you hear the term mental health? Like, what associations do you have with that? Or, in your words, how would you define or describe mental health?
How
Okay, we'll
about
start
looking at somebody's view on life right now?
looking at somebody's view on life. Yeah, great. Got some other ones coming into the chat. Cognitive behavioral challenges. Yep, potentially, right? Mental health can impact how we're doing cognitively and behaviorally, our mental well being, living the life you want to live, general state of well being that can vary based on a situation or in general. Absolutely. Psychological or emotional well being. Yes. Day to day changes, well being, resilience. Absolutely. Yep. All of these things have to do with mental health, right? And some of these I think are really nice ways to define what mental health is. Um, and some of the other things that we look at, like when we would maybe think about a set, would kind of give us an idea of how someone's mental health is doing. Some things we would look at when assessing someone's mental health. It's like subjective experience of distress, right? Like how much distress is somebody in? Are the things that they are experiencing that might have to do with some of the different things that you all put in the chat, the way that they're experiencing those things, is that causing distress? Is that difficult for them? Is that challenging for them? um, and then additionally, does that impair their functioning in different ways or in different areas of their life? um, so even like when you look at, if you think about the DSM, right, which is where all the diagnostic criteria is for different mental health conditions, right? Every single one has its own unique set of symptoms, its own unique set of criteria. But at the bottom of every single one, it says, are these symptoms, right? Or these symptoms are causing significant distress and impairing one or more aspects of functioning, of the person's functioning. So all of the things that you all mentioned, and then the level of distress that someone is experiencing in those areas or not, and whether their functioning is impaired or not, those are some of the things that we would look at and consider in terms of mental health. Um, Someone said mental health is like the weather, it's always there, good or bad. Yeah, which I think is, I appreciate that, right? Because sometimes we only think about mental health when we think about there being a problem, right? Or someone struggling with their mental health. But mental health can also be, right? Mental health, right? Good mental health, right? Feeling mentally well, mentally and emotionally well and stable. Um, and that's kind of a nice segue into our next part of the conversation, chemical health. I would just start with saying same thing and then want to seek your feedback again. But chemical health, right? Another one where sometimes we hear that and we might automatically think of what's wrong or when someone is struggling with their chemical health. But we can also have good chemical health, right? We can have a healthy relationship with substances. But yeah, so same thing for this one. What comes up when you hear the term or read the term chemical health? Someone already said impaired by substances. Yep, that could be one aspect of chemical health. One's relationship with chemicals that is either functional or causing problems. Yep, exactly. Again, right? It could be, we can sort of be on a spectrum of how healthy our relationship with substances is. Potentially using substances in a way that causes that distress, definitely. General relationship with drugs and alcohol, yes. Treatable but not curable, yes. Good point. Very good point, right? Um, when there is some form of addiction, that tends to be a lifelong, right? A lifelong um, process of trying to maintain sobriety, recovery, or a healthier relationship with substances. Yes. Anything else that comes up for folks? Great, spot on, the things that you all put in the chat. Yes, right? Can be the relationship with substances, right? That's kind of how we would define chemical health, and that could be better or worse. And one other thing I like to note here, because I think when we're looking again, we're sort of looking at how do we know if somebody is struggling with their chemical health? Something that can be helpful, right? Again, if you would go to the DSM, you'd have some specific criteria, right? But a helpful rule of thumb, in short, is there continued use of the substance despite negative consequences? And that even if you look at some of the criteria in the DSM, you have a few that all kind of get at that same idea, right? They're more specific, but generally the idea is someone continuing to use the substance despite the fact that it's causing problems, right? Causing problems in their functioning, causing problems in their ability to do their work, causing health problems, causing problems in their relationships, right? Any of these things, if there's continued use despite some of these other things kind of falling apart, that's usually an indication that there's some level of dependence, right? And that is why the person is continuing to use despite these other negative consequences. So, yeah, and somebody said co-occurring dual diagnosis. Yep, that's important. Most treatment programs now for chemical health are co-occurring disorders programs, meaning they treat both chemical health and mental health at the same time, which is so important, right? Because they nearly always go hand in hand, right? Usually people are using substances because there is, right, trauma or some kind of mental health struggle, and they're trying to cope. So being able to treat both at the same time, and it wasn't always like that, and that was a huge problem, right? Sometimes people would go try to get help for one, and they would say, well, you need to go work on your substance use, and then they would go try to get treatment for that, and then they would be told, well, your mental health, you need to go work on that first and then come back to us. And people would really fall through the cracks. So very good that now most treatment programs are co-occurring disorders. And even the ones that I think are like maybe not technically called that, it's still in the programming and in the content. So yes, very important piece. Okay, and then last part here, trauma. I want to start talking about that. We're going to talk about it more throughout the presentation because it's so pervasive in the world, but really, really pervasive in the clients that we serve. So really important to have some level of understanding about trauma. And the first thing I always like to say about trauma is that there are kind of a couple of different ways that we can look at it. And I think two main ways that this term gets used, both of which are valid and okay. But I think it's just a helpful way for us to start thinking about it. So sometimes when people say trauma, they're referring to a trauma, right? Like the traumatic experience or the traumatic event, a trauma. And then other times when it's used, it's referring to the experience of how that event is continuing to affect a person, right? The lasting impact. And I think that's really important because in reality, like multiple people could experience what we would typically consider a traumatic event and which is often a traumatic event, but they might not have that lasting impact, right? Everybody experiences things differently. Everybody has different risk factors and protective factors, things that make them more or less vulnerable to being impacted by an experience in a certain way. So two people could experience the same event, and one might walk away from that still generally being pretty well, and not even experiencing it as a traumatic event or as a trauma. And then the other person does, right? And then they continue to be impacted by symptoms, memories, just different ways of being impacted and affected by this traumatic experience over time, sometimes over decades, sometimes over the lifespan. So that is the other way that trauma gets used, right? It's like a trauma versus trauma impact, or the impact of trauma that is lasting. And then the one other piece about this, another term that gets used a lot is trauma-informed care. And I think it's just important to know what that means, because we do a lot of trauma-informed care at Tubman. And even this training tonight is a part of that, because trauma-informed care is having a baseline understanding of trauma, right? At least enough of an understanding of trauma and how it impacts people and how it can show up and how we can be responsive to that. And having that knowledge and at least somewhat of a skill set around that, that is how we provide trauma informed care, right? When we can use our understanding of trauma and how it affects people to be more responsive to them and in our care of them. So that's really trauma informed care, and that's part of why we do this presentation and spend a decent chunk of this on talking about trauma, so that we can provide trauma informed care. Any questions here? We're gonna keep talking about trauma here a little bit more. Anything at this point? Okay, sounds good. I'll keep going. Okay, so this model of the brain is very, very simplified, right? Of course, the brain is so much more complex than this. But I think this simplified version of it is actually really helpful in the context of what we're talking about and in thinking about trauma and how it affects people. But I do want to acknowledge that, right? This is simplified down, but for good reason. So if you look at this image, right, it's split into, you've got the brain split into 3 different parts, right? And we've got the 3 different parts labeled over there with some of their different nicknames. And I think those are actually really helpful, right? Again, for really breaking it down and thinking about what are the different parts of the brain and how they respond differently in the context of trauma. What happens here when someone experiences trauma or has experienced trauma? So if we start with the smallest, teeniest, innermost part of this image, right? You've got that little reptile in there, the white part of the brain, right? That's our brain stem. Okay, so that's the least evolved part of our brain, and we could nickname that, or it has the nickname the reptile brain, right? And the reason why is because reptiles, that is their whole brain, right? Their whole brain is the equivalent of our brainstem. And I think that's helpful to think about in just like understanding this and starting to wrap our heads around this, because we can ask ourselves the question, right, when trying to understand our brainstem is like, okay, well, what do reptiles' brains do? What are the capacities that a reptile has with their whole brain? They are concerned with survival, and they act on instinct, right? Instinct and survival impulses, involuntary organ function, avoiding threats, and getting their basic needs met. And that's pretty much it, right? And the same goes for our brainstem. Our brainstem is focused on survival. It is impulsive and reactive based on instinct and survival impulse. We could also say, again, like threat avoidance, right? Or better yet, perceived threat avoidance, right? Because we have these other parts of our brain that cause us to sometimes perceive things as threatening, even when they're not. But our brainstem doesn't know the difference, right? If we perceive something as a threat, our brain is going to react in a similar way to try to just protect ourselves, right? So that's our brainstem, right? It's the reptile brain. It's right, very, very focused on how can I just survive and be okay and be safe and get my basic needs met, right? That's it. And then, right, the brain evolved more, right? And we have the midbrain, right, or this particular set of structures in the midbrain, which is known as the limbic system. And it's this cluster of structures that make up what we can nickname the mammal brain, right? And so now you can think about if you have a cat or a dog, right, or think about other mammals, they have additional capacities that reptiles don't, right? They have more capacity for emotion, right? Not just right? Fear, which is actually threat avoidance, but sadness and happiness and, right, maybe sometimes even like guilt or jealousy, right? These even more complex social emotions. They form connections, right? They have social communities and hierarchies. They have more memory. Um, they form right? Actual attachment relationships and bonds. So that's same with our limbic system, right? Those capacities that we also have, that other mammals have, that's where that comes from, is the limbic system. And that memory piece is really important because that's part of what plays a role in the limbic system, sort of being the alarm sound. So I'll talk about that in a second. But that's connected to the memory piece. And a lot of that exists right there in the limbic system, emotion and memory. So we can think, right, again, as the limbic system as either the mammal brain or the emotional brain. So we've got the survival brain, we've got the emotional brain. And then lastly, we've got, right, the most evolved part of the brain, the human brain, because we as humans are the only ones that have this full prefrontal cortex. I believe that some other mammals research, right, they have somewhat of a prefrontal cortex, but not nearly as much as we do, not as evolved as ours, right? And that's why we can do so many things that our beloved dogs and cats can't do, right? Because we have this big prefrontal cortex. So that's the human brain or the reasoning brain or the thinking brain, right? So survival brain, emotion brain, thinking brain, right? And the prefrontal cortex, right? That's that's all those things that we can do that our dogs and cats and other mammals can't, right? Higher level problem solving, executive functioning, self-awareness and self-reflection, um, really advanced problem solving and decision making, being able to weigh and consider all of these different factors and variables and think through them in a way to arrive at a sound, thoughtful decision, right? That's what we get from our prefrontal cortex. Okay. Now, that's a lot, right? How does all of this make sense in the context of trauma? Well, right, although that prefrontal cortex that I just described has all of those really awesome abilities, right, gives us all of those really awesome abilities and capacities, executive functioning, higher level problem solving and decision making. That's all really great. The thing about it though is it's slow, right? It takes time to do those things and sort through all of that information. So what that means is that when we are in a situation where we perceive something as threatening, right? Some part of our brain perceives something as threatening. Usually we're taking in some information through our prefrontal cortex, and then our limbic system, right, senses something, right? Because it's connected to emotion or memory. There's something that we perceive as threatening or overwhelming or unsafe. Again, even if it's not, right? But we perceive it that way. The limbic system sounds an alarm. And what that alarm does is it tells the prefrontal cortex to kind of shut down and go offline, and diverts blood flow to the brainstem, the survival brain. Because that's where, right, if we perceive something as threatening, right, we're going to go into our survival brain. So that's exactly what happens because that prefrontal cortex is too slow, right? So the example I always use is if you're out walking, right, and you are going to cross the street, and all of a sudden you hear, right, you take in some sensory information, and you hear screeching tires, right, and you look, and now you've perceived something as threatening, unsafe, scary, right? This all happens where you don't even think about it. It happens so fast. The limbic system sends that alarm. Prefrontal cortex shuts down because we don't want to sit there with our prefrontal cortex and go, well, that car is like 10 feet away from me, and I have probably, this many seconds or this many milliseconds to get out of the way. Should I go back? Should I go forward? Should I run? Should I jump? It would be too late, right? So the prefrontal right? It's adaptive for the prefrontal cortex to just shut down and get out of the way because it would take too long, and for the brain stem to take over because the brain stem, again, is reactive, right? Impulsive, fast, instinctual. And we would probably in that moment just flee, right? Fight or flight. And then there's also a couple of other responses. Sometimes we look for help, sometimes we freeze. Hopefully, in this situation, we don't freeze. A lot of times, we're just going to run or jump out of the way, right? A flight response, a very healthy, good flight response in that situation that our survival brain did because it took over, because the limbic system sounded that alarm, and the survival brain said, we're just gonna act, right? And we're gonna just survive and get safe. But that same process can happen sometimes in situations that are maybe still threatening in some way, but more like emotionally threatening or feel relationally unsafe. But again, sometimes they're not. That's the important thing, is it can be perceived as uncomfortable, right? Or it is uncomfortable, but uncomfortable is perceived as unsafe, right? Even though it's not necessarily. And when someone has experienced trauma, and especially when someone has experienced multiple traumas or pervasive trauma, right? Like maybe growing up, a lot of our clients have, their brain, their brain has gone through this process so many times, right? And it's gone through this process so many times while it was developing, while the brain was developing. This is the process that it was going through. Threat perceived, alarm system sounds, prefrontal cortex shuts down, brainstem activates, and we act on a survival impulse. And like anything else, the more we do it and the more we practice it and the more reps we get, the better we get at it, right? The more smoothly and efficiently and quickly we can do that. The same thing goes for this process. So when someone has experienced ongoing trauma, their brain is really good at going through this response pattern, right? And they become more likely to have trauma responses, more likely to perceive things as threatening even when they're not, because that's adaptive, right? If I've experienced a lot of unsafe, threatening things, right, my brain is going to get wired to perceive those things so that I can try to protect myself, right? But then if the brain is looking for those things and is hyper vigilant of those things, then we're going to be more likely to perceive things as threatening or unsafe, even if they're not, even if maybe they're just uncomfortable, right? Or someone is maybe mildly frustrated with us, and rather than feeling like, oh, they're just mildly frustrated with me, that's a little uncomfortable, instead the perception is they're really angry at me, they're going to hurt me, I'm not safe, right? So the brain becomes wired, right, for this trauma response pattern. And that is a really, really important thing to know, because that is the case for a lot of our clients, right? They've experienced a lot of trauma. And so, right, their brain is more likely to go through this trauma response pattern and process. And sometimes that can show up in ways that on the surface for us might be difficult to understand, right? And we might, see that someone is reacting a certain way and we're not sure why, right? And sometimes that can even show up in ways that can be like frustrating or uncomfortable for us, or that we might, that we could take personally. And it's really important to try not to do that. And having this understanding, right, everything that we just talked about can be really helpful when it comes to that, right? Because we can know that this behavior, right, this last bullet point, this behavior isn't on purpose. It's not personal. They're not trying to, hurt us or make us uncomfortable or whatever it might be, right? They're just trying to feel safe and secure, right? And something was perceived that felt threatening or uncomfortable, or, even if it was just uncomfortable, it was perceived as threatening or unsafe. And their brain is having a trauma response, right? So we're going to talk more about some different skills that we can use to approach people when that is the case. But again, having this background, I think, is so important. We don't want to just talk about the skills and how to respond. We want to actually, ideally, have some understanding of what is happening and why it's happening. So I think this is a good foundation for that. So, any questions at this point? Okay, sounds good. All right. So before we get into, we are going to talk about, we're going to kind of sidestep a little bit. We are going to talk about like crisis de-escalation skills that are really helpful to use when a client is in a more heightened state. But let's kind of take a breath from that and a little sidestep here and just talk about some skills that are helpful just in general, right? Just for interacting with clients in any capacity. So to start with, I know some of these might seem kind of simple and straightforward. Some of them are. That's okay. That's good, right? Hopefully that means that they're easy to do, but they're also really helpful. Like this first one, active listening. I know that might seem simple. Eye contact, nodding along, asking open-ended questions and giving the client time to talk. Body language, right? Facing them, looking at them. Um, and if we're on the phone and they can't see us, right, just using our tone, using little, call them minimal encouragers, little like, okay, right, little things to just kind of let the person know I'm still here, I'm still listening, keep going. All of those things, right, just give the person the message that we're there with them and we're listening. And I know that might seem simple, but the reality is that for a lot of our clients, they don't have a lot of that in their life, right? I mean, we've gotten the feedback from some clients like we're the only person that they get that from. So this can be really significant to just show presence and engagement and active listening. And then we've got what we like to call contact statements. This is that term maybe is not as familiar. It's a contact statement ideally is short and sweet, right? It's a short and sweet to the point statement that just like gently reflects on some aspect of the client's experience, right? So it involves active listening, right? Because if we're actively listening and we're really engaged, we can be tracking all of these different things, right? We can be tracking what the client is saying, how they're saying it, their tone, their volume, their body language, their breathing. And when we're doing that, then we might pick up on something, right? Like, oh, as soon as they started talking about this part of the situation, they started to get a little bit louder. It seemed like their breathing got more rapid or more shallow. Their tone changed a little bit. I feel like I'm seeing that there's more distress associated with this, right? So we could make a little contact statement around that, right? And just say, I noticed that as soon as you started talking about this part of the situation, your voice kind of changed, right? Even just something simple like that, just really making contact with their experience. It can be really validating. It can really help clients feel seen and understood. And then sometimes on a more concrete level, it can help us sort of hone in on the part that's maybe kind of at the heart of things, right? Or the part of the problem that they like really need some extra support around. So contact statements can be really helpful for all of those reasons. We could also make a contact statement about an emotion, right? So, we're kind of hearing what they're saying, and it seems like, and sometimes we're wrong. So it's nice to say these a little bit like tentatively. That's actually good. It gives the client space to say, I don't know if it's that. I think it's more this. And that's good, right? If they do that, that's good. We don't need to feel bad about getting it wrong. Us saying it, helped the client orient to themselves and like hone in on on what the emotion they are experiencing, right? So if they say, oh, I don't know, I don't think it's frustration. I think I'm just really sad, actually, right? That's a good thing. They're tracking their own experience. So so those are contact statements. And then we've got reflection, which is similar, but just a little bit more kind of concrete. And just we're paraphrasing, right? We're hearing what they're saying and we're reflecting it back, and we're just letting them know, okay, so I'm hearing that you've got this going on and this, and then you also talked about this. And that can also be a nice time to say, am I missing anything? Or is there anything that we haven't talked about that you also want to mention? Right. So just reflecting back, letting them know that we're listening, and then collaboratively tracking together the different pieces that we're talking about. Okay. And then next we've got validation, a super, super helpful skill. This might be, if I was going to kind of really plug one of these and say, if you're going to remember one, remember this one. This one might be that. Really, really useful. It also, you kind of have to do some of the other ones to be able to do this, right? But validating is just, right, any comment that we make where we are giving the client the message that what they are saying matters, it makes sense, what they're feeling matters and makes sense, and they matter and they make sense, right? um, Validating, right? Help try saying things to try to help the client feel valid, feel like their experiences, their emotions are valid, they're important, they matter, they're real, all of those things. There's a little note here that I do think is helpful. Sometimes the client is saying something, and a particular part of what they say, maybe we don't want to validate that particular piece, right? Especially if it's a belief, like a limiting belief, or right, a perception or interpretation, because sometimes we get those wrong as humans, right? And that's okay, because they're informed by all of our different experiences, and right? And we would never say that. We would never say your perception is wrong, but we also don't want to kind of like jump on the bandwagon, right? And co-sign a maladaptive belief, right? Like I'm not good enough, or I can never do anything right, or something like that. But what we can do is validate the emotion, right? Validate how helpless they're feeling or how discouraged they're feeling. That we can validate. Um, Exactly. Yep. Emotions are always valid. Someone said this in the chat. Emotions are always valid, but beliefs may not be correct or accurate. Spot on. So when in doubt, validate the emotion, right? We can always validate the emotion. Um, be present, right? So we talked about active listening and trying to convey presence, right? We also want to try to actually be present. Of course, we're human, right? We're going to wander sometimes. We're going to think about what we want to have for dinner. I'm thinking about that a lot, but we try to just refocus, bring ourselves back, and be as present as we can be, right? Really be in the moment with the client. It makes a huge difference. They feel that. I would also even note that, especially if for a lot of you, this is going to be your first time, like working with clients in this specific capacity. Sometimes that brings up, right, nervousness, anxiety, imposter syndrome. This is a really helpful response to that. If you start feeling like you're kind of getting in your head, and you're thinking about, okay, well, what am I going to say when they're done talking? Actually try to let go of that a little bit and try to just focus on being present. Usually the more you do that and you're just authentically present with them, you're authentically curious about their experience, then you're going to know what to say. It's just going to come organically. So being present is also a helpful sort of a thing to anchor to, if you're ever feeling like nervous or imposter syndrome type of stuff. And then I think lastly here in this section, be curious about underlying needs. So, right, again, as you're tracking, as you're actively listening, like start to notice if you're picking up on themes. So they're talking about a few different things or a handful of different things, but you start to notice, oh, it feels like there's this theme of like they don't have a lot of stability, or oh, it feels like there's this theme or this kind of common thread where they're really lacking connection or support. if we can notice those and hone in on those, that can help us figure out, okay, what kind of direction do we take here? You can make a contact statement about that, right? And just say, it sounds like overall you're really lacking stability right now. And if the client says, yeah, that's really true, right, then you can go, okay, so maybe that's a helpful thing for us to focus on and look at a little bit more. So be curious about underlying themes and unmet needs. Okay, we are going to do a quick poll to just get you all thinking, right? Kind of going back now to thinking about a high intensity situation or working with a client who's in some kind of heightened state, to just turn inward for a moment and think about what comes up for you when you imagine being in that situation. And there's going to be a poll. You can check multiple responses, and then we'll talk about what we find with our collective answers. All right, so we've got our responses here. And my first observation, just as I start to look at these, is how, right, there's a response, probably multiple responses in for every single one, right? Multiple people endorsed all of these. And I think that is helpful to point out and know, right? Because it's good to know that you're not alone, right? These are all really normal feelings and thoughts to have when thinking about dealing with a crisis situation. Um, and when we look at some of the specific ones, right? Like, I don't know if I have the tools to handle that, right? Totally understandable, right? And that's part of why we do this training tonight, is we kind of start to set the stage for that, right? Of course, we can't talk about everything tonight, but we do talk about some tools that can be helpful in that situation. Feeling nervous, right? Over half the group said they're feeling nervous. I still always feel a little bit nervous when I think about being in a crisis situation. They're unpredictable, right? And we don't know exactly what's going to happen, right? They require a lot of us. So I think it's super normal to feel nervous. Right? Okay, so it looks like this one might feel threatened or unsafe. No responses tonight. Oftentimes that gets some kind of response, and I think that makes a lot of sense too. Because again, it's unpredictable. We don't always know exactly what's going to happen or how we're going to feel. Will I have help if I need it? That's huge, right? So that one too, over half the group. And we're going to talk more about that, but we always want to have help if we need it. We really want to know, like, what are our protocols, right? Who are your point people? Who's your supervisor? What's the best way to get a hold of them in a situation like this? That's something I really want to emphasize. That's something that we always want to know, is like, if something happens where I need help, how and where do I get that help, right? Because that is important. Worry it would be triggering. Yeah, right. It could be. Sometimes it is. So I think, again, super normal thing to think about. Some of the skills that we're going to talk about can even be helpful in that regard, right? Like, how do we ground ourselves in these situations too? And then, yeah, a lot of people also feel mostly confident in responding. And I like that, right? It's important that this poll allow you to check off multiple of these, because multiple of these can exist at the same time, right? You can be thinking, do I have the tools to handle this? I think I do. I feel mostly confident. And also, am I going to have help if I need it, right? You can feel all those at the same time. Or you can feel like, I feel a little nervous and I feel mostly confident in responding, right? So these can exist simultaneously. Okay, so let's talk about some of these different pieces. So more skills here, but these ones, right, really specifically for engaging in some kind or working with someone who is experiencing some kind of crisis or is in a heightened state or dysregulated state. It's not perfect, right? It's hard for it to be perfect, but I try to put these in chronological order. So you can sort of think of these as like, ideally, this is kind of the order that you'd want to do these in. If possible, that would be most helpful. So first things first, doing some grounding for yourself, right? Because even if we go back to that brain image, right, we want our prefrontal cortex to be online as much as possible, right? So that we can be really, we don't want to act impulsively in when we're trying to help someone else through a crisis. We might have to be the prefrontal cortex, right, for this other person whose prefrontal cortex is offline. So that means we have to do a little bit of grounding ourselves, right? So with this, I even think about like if I'm at the office and I, hear something out in another part of the building, right? And it sounds like, oh, something's going on. I don't know if that's good. I'm going to go check it out. Even just on the walk down the hall, right, to the group room or wherever it might be, or down the stairs, I can be doing a little bit of grounding as I'm taking that short walk, right? I can be feeling my feet on the floor. I can be taking a few deep breaths. Deep breaths are your best friend, right? It's the grounding technique that we almost always are going to have with us, right? A nice slow breath in with a longer exhale. If your exhale is longer than your inhale, that's going to activate your parasympathetic nervous system, which is the part of the nervous system that helps you feel more calm and more relaxed. So deep breaths, slow breaths, longer exhale. You can even count if that's helpful, right? Like in for 3, out for 5, or in for 4, out for 6. Help slow your heart rate down a little bit. Feeling your feet on the floor, right? Really, these like body oriented somatic grounding techniques can be so helpful. And then even if you have any little kind of self-soothe thing that works for you. I've had clients who, when they put their hands kind of on their upper shins, that feels really soothing and grounding to them. I notice I always will grab my own hands, right? And just kind of, right, almost like massage my own hands a little bit, just kind of feeling that contact, feeling my skin, right? Squeezing a little bit, right? It just grounds me, just a little bit soothing. So know yourself. And if you have anything like that is helpful for you, and just do a little bit of those things, even if it's for 20-30 seconds as you're approaching the situation, right? The next thing that is helpful to think about, right, now you're approaching the person, right, or the situation, and you really want to think about what you're conveying non-verbally, what you're conveying with your body, your tone, right? So not even what you're saying, but just your volume, your tone. So non-verbals and paraverbals, using a really calm voice, quiet volume. Sometimes there's the instinct when things are loud, right? We think, well, I'm going to get loud so everyone can hear me. Actually, if we stay quiet, that typically is going to bring the other person's volume down, because it's natural for, right there. If you're quiet, right, it kind of pulls them, and they have to be quieter to hear what you're saying. So being mindful of your volume, being mindful of your tone, right, really gentle tone. And then posture, to open posture, right? Just notice what you're conveying with your body. Are you looking at them? Where are you in the room, right? If this is an in-person situation, we want to be mindful not to block doors or exits. And then also, like, if they're sitting, right, we want to be sitting. One time, long time ago in the building, I walked downstairs, someone was in a really distressed state and she was laying on the floor, and I just got all the way down to the floor, right, and as low as I could, right, versus having people tower over you. If our prefrontal cortex is offline and we're in our survival brain, we're going to perceive things as even more threatening. So that means we have to really try to be aware of coming across as non-threatening as possible, and being on someone's level versus towering over them or blocking their exit. Big part of that. Okay. So I want to just be thinking about those things and how you're approaching the person. And then, right, starting to engage with them. First and foremost, we want to focus on regulation. Sometimes it's easy to kind of have the impulse to jump right into problem solving, like, okay, what's going on? What's the problem? The the person is already in a heightened state and a dysregulated state, right? So what we have to focus on first is just regulation, right? Getting back in the window of tolerance, so to speak, right? Because they're not really going to be able to engage in effective problem solving if they're not regulated and if they don't have their prefrontal cortex online. So that's goal number one, right? And we can start to think about trying to help them identify some skills or resources that they can use, maybe even doing some of the things that we just did when we were focusing on our own grounding, right? Can we help them do a little bit of grounding? So just offering a couple of options. We don't want to overwhelm them, right? But just saying, I wonder if we can first just try to do a couple of things to help you feel a little bit better, right? To feel a little bit safer. Um, is there anything that you can think of? Do you want to get a drink of water? Do you want to step outside? Right? Maybe leaving it at that for now, right? Or do you want to we could take a couple of deep breaths together. Let's just first try to focus on feeling a little bit more grounded here. And then we'll get to the rest of it. Okay. So trying to help engage them in that, offering some options, because again, if their prefrontal cortex is offline, which it probably is in this kind of state, it's going to be hard for them to think of things. So trying to offer some things for that reason, but not too many because we don't want to overwhelm. Maybe starting with offering 2 things. If they don't want to do any of those things, then maybe we suggest one more, right? If they're still not sure, then maybe we say, what if we just sit together here for a second? What if we just sit here and breathe? Right? And just give them a minute, right? Just a calm, just having your calm, regulated presence there is good, right? Then we get into co-regulation, and that can actually help their nervous system regulate. So even just sitting with them calmly can help. Okay. So that's that piece. And then from there, if they're feeling a little bit more calm, a little bit more regulated, as they're feeling a little more calm and more regulated, then we can maybe start to get into some problem solving. So in this next piece, I want to say we could use this in 2 different ways. We could use this kind of in conjunction with the part that we were talking about just now, and the last one on the last slide, focusing on regulation. We could ask this question if they're having trouble identifying what they want right now, just to feel a little bit better or more calm, right? We can ask, is there anything that you typically do when you're feeling like this? So engaging, helping them identify existing skills or resources. We can also ask this question and take this approach once we get into trying to help problem solve whatever the precipitating situation was. So if they're just feeling really frustrated because they just got bad news, and right, they're trying to navigate some kind of situation, and they just found out that something didn't work out, right? We can ask that same question, like, has anything like this happened before, and what did you do in that situation, right? Or what have you done in the past when you've hit a wall like this, right? And just seeing, there may not be, but our clients are really resilient and typically have been through a lot. And so sometimes helping them think about, oh yeah, I have experienced something like this before, and this is how I navigated that can be helpful. So maybe using this question to engage in a little bit of problem solving once they're feeling more calm. That's the important part. Regulation first. This piece, right? This is where I would say this piece is the one that you can't plug it in chronologically necessary. This is something that ideally is sort of like you're doing all along, right? At every point in the situation, you're constantly knowing your limits and assessing, do I need to get help? And go ahead and get help if you need it. That's okay. If you're not sure, go ahead and ask for help, right? I would say when in doubt, ask for help. There's nothing wrong with that. And in a situation like this, like two brains are better than one, right? Two prefrontal cortexes are better than one. So, so throughout any crisis or heightened situation, just be checking in, know your limits, and get help if needed. So we could really plug this in at any point in this process. And then lastly, and this would come last chronologically, debrief. Really, really want to emphasize that. Debrief, debrief, debrief. Talk with your supervisor, talk with a colleague, and just get some support, because these kinds of situations, even if we do our grounding and we are staying fairly calm throughout, that that still takes a toll on our nervous system, right? To be engaged in a crisis situation and to be the anchor, right? And to be the calm, grounded one. So debrief, because it will help you process and it will help you release some of that stress from your mind and body. So really important at helping to reduce burnout and just keep you well. So always debrief. Okay. Let's take a second here. Take some deep breaths, maybe take a couple stretches if you need to. I know it's a long day and we're covering a lot. So yeah, take a minute, maybe take a drink of water. Okay. Let's keep going here. We're in the home stretch. We've just got a little bit left. A little bit here quick, a couple of notes on client safety and sort of really light safety planning. If you're picking up on something when talking with a client or working with a client, and you start to have some concerns that the client may be at risk of hurting themselves in some way, the best thing to do is just ask directly, right? Gently, respectfully, but directly. We don't need to be scared to ask. We don't need to worry that asking is going to make them do something that they otherwise weren't thinking about. That is not the case. We just want to ask and be clear. Are you thinking about hurting yourself? Have you had thoughts about hurting yourself? Are you feeling unsafe? Are you feeling like you can keep yourself safe, right? Anything like that. Are you feeling concerned that you can't keep yourself safe, right? So different variations, but just asking really clearly and gauging where the client is at. And this, right, I mentioned this before, right? This is where we really, really you want to know what is your team's protocol, right? What is this? What are the specific steps that you're supposed to take? And I say this, right? I know this is general, but that's because you are all in different roles on different teams. So, right, we can't say here's exactly what you're going to do, because it might be different given your role and your team. But make sure you know this, right? And if it doesn't come up in any of your initial training or onboarding, go ahead and ask, right? If there's a crisis, if I'm talking with a client and then it turns out that they are a risk to themselves, what do I do in that situation? So know who to contact, when, how, the most efficient way to reach them, things like that, right? Know your team's specific protocol, resources that they want you to utilize or contact, all of that. And yes, seek help when appropriate. Oftentimes it is going to be appropriate in a situation like this. And then you can offer the client some resources. But again, maybe your team specific protocol is to loop someone else in, and then they do that with you, and together you give the client some resources. But there are different resources. There's different options, right? COPE is Hennepin County specific. It's the county crisis team. They can talk with clients. They can come out and assess in person. 988 will take you to the county crisis team. If you're in any other county outside of Hennepin County, clients can always go to a local emergency room, right? If they know they want some extra support and they want to get an assessment, they can go to the local ER. There is a unit called the Empath unit through Fairview Southdale Hospital. That it can be kind of a nice sort of in-between option for clients. It's somewhere they can go, they can get an assessment. They will be talked to by different members of a team. It's a safe place to be. And then the team kind of helps gauge, does this person need to be admitted? And if so, where do they want to be admitted and how can we get them admitted? But the goal is really to see, is there a way that we can help you be safe without being admitted to the hospital? And let's get, and maybe an intake for a day treatment program set up and have you meet with a psychiatrist and have a follow-up plan to meet with a psychiatrist again, and things like that. So that can be a useful resource as well, the Empath unit at Fairview Southdale. So a few different options. COPE is great, right? A county crisis team is great because they can come out and assess more. And that's all they do, right? That's their whole job. So those are the situations that they're used to navigating with clients. And then they're super in the know about different resources and options that they can connect clients with. So I think it's helpful to know this, right? I doing this for 9 years and having worked with a lot of clients, it's nice. I feel relief when I think about that. I like knowing that there are these crisis teams, right? COPE, that I can even call with clients and help, and then they can go out because I can't go to a client's house and help assess them, right? Yeah, they can just walk clients all the way through it, which is really nice. Okay. In right having that conversation, keep in mind some of the things that we've already talked about, right? Responding calmly. We don't have to panic if a client is, right? If they're talking to us about it and they're letting us know that they're feeling unsafe, right? They're already showing that they want to get some help and support around this. So we don't have to panic. We can just talk with them, loop in some other support and figure out the next steps, right? So try to remain calm, try to ground yourself. Right. The more calm you stay, the more calm the client will stay typically. And just be gentle. Keep in mind, right, some of those spatial things, especially if a client is feeling more dysregulated, and offer some options. That's really huge, right? Especially when it feels like, okay, we actually probably do need to get this client some additional support. The best way to get them to buy into that is if we can give them some options, because then, right, they have some choice in the matter as well. So that tends to feel good. Get them on board. And then in the event that you've noticed some things, right? You're noticing some mental health symptoms, some things that the client is struggling with, but you've talked with them and there's no safety risk, right? In that case, then maybe that's just a situation where you make a referral, right? Maybe you refer to the Tubman clinical team or some other supportive service, right? The resource advocates can help look at other options, other programs, maybe looking through the program guide, just see if there's something else that it seems like could be helpful to the client based on what they're experiencing. It's their choice if they want to pursue some other kind of supportive service or not. If not, that's okay. But yeah, if you notice them struggling and want to talk with them about some options, that's a good thing. So if we can help be that connector. Okay. Got just a couple of scenarios here, a couple of situations. So we have talked about a lot tonight. Let's try to synthesize some of that and just see what comes up for you when you think about some of these different situations. And the question here, right, is intentionally, what might you take into consideration? So it's not how would you respond step by step, right? If you want to also think about how you would respond, great, but also just think about what your process would be. How would you be conceptualizing the situation, what's happening for the client, and then yes, maybe also how could you respond? So imagine you're talking with a client about housing resources. Upon being given a list of options, the client becomes upset and states she's already tried all of those avenues with no success. She becomes tearful, begins to raise her voice, saying nobody will help her. The system treats her unfairly, and this is just hopeless. So take a moment, and when you have thoughts, feel free to unmute and say them or put them in the chat. But what would be coming up for you? What would you take into consideration here? How might you respond? Yeah, I see a hand up. Want to jump in, Andy?
It can feel like when somebody's rattling off a bunch of options to you, like in the moment, it can kind of feel like you're just throwing a bunch of stuff at me. I don't know how to respond. And then you can have like this trigger to like all of the past failures that you had are all coming down to this one moment. Now you're afraid of success and you can have like a complete anxiety shutdown. So
Yes.
that's something that I would consider.
Yes. Yep. Absolutely. Yep. Maybe the client's response is maybe giving us information that we need to just take a step back, right, and slow down. Maybe it's just feeling like too much, and she's getting overwhelmed. Yep. And we could potentially even say that, right? We can just say, maybe this is just feeling like a little bit too much and is feeling overwhelming. How about we just slow down, right? Let's just slow down, and then we'll figure out next steps. Yeah. Seeing some of the other responses in the chat, empathize, try to understand why the client is feeling the way that they do. Absolutely. Would take into consideration that the client may have had previous trauma connected to housing. Definitely, right? And is currently struggling with housing insecurity, which is traumatizing in and of itself, right? I don't know if my basic needs are going to be met, right? Am I going to be okay? I don't know. Yes, someone else also said the options could be overwhelming. And yeah, maybe it is something that they've tried before. And yes, there could be trauma here. Yep. So glad that everybody's thinking about that. And consider culture and or experiences within systems that may be systematically negative and validate that. Yeah, right? Like there's a good chance that, right? I don't feel like I'm being treated fairly in this system. That could be very true, right? And so it makes sense that it might be feeling additionally hopeless, right? Or especially hopeless, if it feels like this is an uphill battle and this system is not for me. So, yeah, I think a lot of validation here is really important, right? Along with some slowing down and focusing on regulating, right? Let's pause. Let's just attend to the feeling and the regulation, and then we can get back into problem solving, right? And once we do get back into problem solving, something that could be helpful here, right? Because it can feel discouraging when like you've tried different things and then you ask for help and then you get a list of things that you've already tried. So we could say, let's take a step back and let's go over all of the things that you've tried already, especially recently, right? Because if it's something you've tried, but it was a long time ago, that might be worth trying again, right? Because waitlists change and programs change and criteria change, so potentially, but let's look at what you've tried recently, and then I won't suggest those things, so that we can make sure that we're not being repetitive and we're putting our energy right to options that might actually work. So yeah, really trying to meet her where she's at. Good. Okay, great. Let's go ahead and move on to the next one. So another scenario, imagine you are with a small group of children in the children's center. A young boy hits one of the other kids. When you attempt to intervene and address that behavior, the boy yells at you and then he runs away to hide under a table. So same thing. What would you be thinking about? What would you take into consideration? maybe some different things you would do in your response. Yeah, running away and hiding could absolutely be a trauma response, right? That he's had to use before. It's definitely a flight response for sure, right? So is that because of past trauma he's experienced? We can't know for sure, but it's definitely a flight response. He's feeling overwhelmed or threatened. We know that, even though that wasn't our intention. Yeah, it takes kids longer to regulate. Yeah. Megan said I would get my body down to the ground. Yeah, so get on his level, right? Kids are already being towered over, right? Just because of height. Would get my body down to the ground, use a calming voice, focus on helping him regulate. Yeah, absolutely. Yes, I have to address the behavior, but also maybe even the original behavior comes from trauma, right? Not just him, yelling and running away, but maybe him initially hitting that other kid, right? So if he was, thinking that he was protecting himself in some way, and then he feels like he's getting in trouble for that, right? No wonder that feels overwhelming, threatening, maybe even unsafe. Again, even though that's not our intention at all, we're trying to keep all the kids safe. Yeah, so him running away is a protective reaction and needs to be treated with calmness and patience. Definitely. Yeah. And ideally we have help, right? Maybe we're alone, maybe not. If we are, it's a little trickier, right? We've got all the kids, but then also these two kids, one that was just hit and then one that is having this response. If we have help, we can be attending to, right, both kids at once, right? We can tag team. Great. Absolutely. Those are all the things I would think about too, right? Like this little one is doing his best, right? A lot of times when these interactions happen, we don't see everything. We don't know exactly what happened. We don't know why he hit the other kid. So approaching with calmness and curiosity, right? And again, really initially just trying to convey you're safe, right? So if we go up right away again and say like, well, what happened? Did I miss something? At first, right, it's just like, it's okay, you're not in trouble, everything's okay, right? Maybe he might need just a little space and time, right? So it could be helpful to, yep, get down on his level, right? And maybe even say something like, um, everything's okay, you're not in trouble, I'll be here when you're ready to talk, right? If you're not ready yet, that's okay, right? We can talk in a few minutes, and just give him a moment to process. But even just kind of hanging out near him can be helpful, right? So he knows that he's not alone and it's okay. Good. Okay. Great. Um, so a handful of different resources, right? I mean, there's so many, but this is just some. There's some crisis lines here that can be really helpful to be aware of. Some of these websites are just ones that have like more information and kind of good digestible information on mental health, chemical health, things like that. So if you're interested, those are there. And then I think the next one we've got some, yeah. So these are some books. We kept getting the question of like, are there books that you would recommend? And these are some books that I would recommend. These are really well-known ones in the field. Body Keeps the Score is about trauma and how it's all happens and is held in the body. My Grandmother's Hands is on racialized trauma. Healing the Fragmented Selves of Trauma Survivors, really down to earth read, really helpful when just understanding different kind of different ways of looking at trauma and how it shows up for people and how to work with it. In the Realm of Hungry Ghosts is on the connection between addiction and attachment and trauma. So really great one there too. And that's my dog. That's my little assistant who's been sleeping on the job tonight. But yeah, so that's it. That's what we've got. Any questions? I know it's a long night, so it's okay if not, but I want to open it up.